The Interim Joint Committee on Health, Welfare, and Family Services. This is meeting number 3. The date is Wednesday, September the 28th, 2022. We're going to call this meeting to order. Madam Clerk, please call the roll.
Senator Rocky Adams. Senator Berg. Senator Carroll.
Here.
Senator Givens. Senator Harper Angel. Senator Howell. Senator Kerr. Senator Meredith. Senator Nemes.
Present.
Senator Wise. Representative Bentley.
Here.
Representative Bowling.
Here.
Representative Bray. Representative Birch. Representative Dotson. Representative Elliott. Representative Fleming.
Present.
Representative Fraser Gordon.
Here.
Representative Marzian. Representative Gibbons Prunty. Representative Rayburn.
Here.
Representative Raymond. Representative Riley.
Here.
Representative Sharp.
Present.
Representative Sheldon.
Here.
Representative Tate.
Here.
Representative Weber.
Here.
Representative Westrom. Representative Wilner.
Here.
Co-Chair Mosier.
Here.
Co-Chair Alvarado.
Here. All right, very good. It looks like we have a quorum. The first order of business we have is approval of the minutes from the. We have two sets of approvals to look for. The first one is July 20th, 2022. We'll entertain a motion. You have a motion. Is there a second? Second. All those in favor, please signify by saying aye.
Aye.
Any opposed? All right, those are approved. The next are the August 25th, 2022 minutes. We have a motion for approval. Is there a second? You have a second. All those in favor, please signify by saying aye.
Aye.
Any opposed? All right, those minutes are approved for both of those meetings. All right, we've got a kind of a robust agenda today. The first thing we're going to take up is going to be our regulations. On item number 7 on the agenda is consideration of referred administrative regulations. These have been out for a while. They've gone through the Administrative Regulation Subcommittee as well. Any discussions, concerns? If not, there's no discussions or questions. They'll stand as having been reviewed by this committee as well. All right, very good. All right, the first thing we're going to talk about, kind of a general theme today, is based off of a bill that was proposed last session, House Bill 457. I think, which is a broader discussion. We've had a lot of discussions on PBMs. We've had some testimony this year based on the fact that we've gone to a single PBM system within Medicaid, and we've heard from the cabinet the savings that have come into Medicaid as a result, and really it appears to be a rather large amount of money that we're going to be saving with that. That prompts us to start looking at PBMs in general in the state of Kentucky, and I think it's important for us to have this discussion. I've asked Representative Sheldon, this was his bill, and I think we all have a copy of that before us also. Representative, if you'd like to go to the table. And I think we've also got Kathy Hanna. If Kathy's here, it's good to see you, Kathy. We work together in clinical settings as well. So if you'd like to both please introduce yourselves for the record and begin your testimony whenever you're ready.
Thank you, Co-Chair Alvarado and Moser. Thank you so much for being here, allowing us to be here and present this again today, keep the momentum going. It's a great piece of policy. It got through the House last year and just ran out of gas over here, and we're in the Senate, and we're looking forward and appreciate you asking us to come here and talk about it again. We obviously, it can be fairly complicated. It's a very large piece of legislation, but the simpleness of it you'll see today, and we're gonna try to do that. So let me start by letting you know that you're going to get more information about pharmacy benefit managers really than you could ever imagine, but it's, again, we're working on trying to keep it very simple. So it's more of a supersized, self-serving influence that PBMs have on prescription drug costs. And for those of you all that, I think you know what they are, but they're basically, if you took manufacturers over here and you took insurance companies and pharmacies, wholesalers, the PBMs are in the middle. They handle all the money. It flows through them one way or the other. So why do we concentrate on PBMs? They're highly unregulated, and the rest of the country is on alert, and for years now, this has been an issue for our state and many others. You will hear today from PBMs that will tell you how pharmacy care and really pharmacy in general in our rural states in America are being threatened to the point where there's not going to be any rural pharmacies out there if we don't do something about this. It's a bigger problem than that. It's not just number of pharmacies. And you'll hear that through the testimony today. Rather than to repeat them, I'm going to let these experts tell you their part. But let me go. As a legislator, a pharmacist, and an employer, and a patient, that's all the hats I wear. I have experience with PBMs through multiple prisms. My invitation to join the National Council with legislators all over the country was priceless. For 3 years, we worked and we confirmed and prioritized that PBM reform, even in our recommendations of about 8 or 10, was number one on the list to try to reduce drug costs. That was our goal in that committee. I see every day the role PBMs play in the various hats I wear in the cost of a prescription drug. That's why it's so important, and you'll hear more about that. As legislators, we recognize the problem of the PBMs within Medicaid managed care, and we had to address that here a couple years ago. The chair mentioned that. Senate Bill 50 in 2020. Senate Bill 50 required the Department for Medicaid Services, and this is going to be important that you understand how well Senate Bill 50 worked and why we need to look at the other part, the other PBMs that are doing business in our state. And you're going to see what Senate Bill 50 did for our Medicaid program and why in the world we would let our consumers be subject to such manipulative type self-serving behavior is beyond me. And you're going to hear a lot more about that. That Senate Bill 50 required the Department for Medicaid Services to just contract with a single PBM for the purpose of administering pharmacy benefits. And it's working, as I said. In spite of all the noise opposing Senate Bill 50, and we were all there. In fact, much of it, like the email many of you received this morning, opposing 457. Same rhetoric, same talk. Senate Bill 50 passes. Contrary to that, PBMs and insurance companies argued then that it would dramatically increase the operational costs of Medicaid. And they stood and they fought us on Senate Bill 50. And thank you, Max Wise, for sponsoring Senate Bill 50 and allowing me to be part of that over in the House. So thank you very much. And we're going to talk about what Senate Bill 50 did, some real numbers here, so that we can get further down the road. It established a transparent reimbursement model to pharmacies, ensured patients had access to pharmacy care of their choice. That's important. And based on testimony from Secretary Friedlander and Medicaid Commissioner Lisa Lee, we know that the state has increased the amount of rebates collected by the state more than 50%. Most recently collecting $1.2 billion in drug rebate just this year. I have a slide for, I think that's coming. You got it up now? Or okay. So this resulted, there were some chargebacks on those rebates. I asked for some confirmation on what other means on the pie chart that you're going to see coming up here. And this pie chart shows $482 million to the Medicaid system savings. You see those parentheses. So we actually injected $482 million back into the Medicaid program because of Senate Bill 50. That's the nuts and bolts of it. On top of that, a few years prior to that, and Senator Wise was involved in this as well, we discovered a practice known as spread pricing that PBMs use, where they're charging the pharmacy one thing and then charging the people they work for a different amount, and that was a spread, and they were keeping the money in between. So we uncovered that, and it was $123 million. Some of you may remember. You take that, so Senate Bill 50 spoke to the spread pricing. It spoke to the behavior. We had to put some rules in place. We knew the RFP would go out. We needed some rules. That's what the 13 pages from the House did. Said, look, we're gonna put in some rules here, simple rules. Keep the ground fair. Fair is all we really want. Nobody wants to tell anybody what to do. We just need it fair. And any good Well, I'll get into that part later. But that is amazing. So if you go to, and I think side 3, as an employer, I'm going to talk about, I noticed that the company, and let me tell you, again, I'm going to put on different hats as I go through here. I worked for a very large company, 33 states, 16,000 employees. As we started going through ours, and so as an employer, I'm going to talk for a minute, because employers, we all heard from them last year, oh, our premiums are going to go up, our premiums are going to go up, and there's absolutely no factual data for that, and we're going to show you today, and there's going to be experts testify to the complete contrary. And if that were the case, why did it go way down at Medicaid? Why? I mean, there's no reason for it. So I'll just tell you what we did. We immediately saw that these people were taking money from us, because we happen to own pharmacies and we own insurance companies and we're self-insured. What a unique position to be in. We literally could go all the way around the circle and find out where the money was going. And we found out they were keeping our money. So we fired our PBM, which was one of the big 3, by the way. And interesting story, they didn't want to get, even though we're self-insured and we own the data, we requested the data from Blue Cross Blue Shield, which was not the PBM, but our provider. And they didn't want to give us they didn't want to give it to us. They didn't want to give us the data, our own data. We literally had to press for 3 months. When we got it, it was all, and you hear this same story from all employers that try to look into it. And we got it all, and it was all on spreadsheets we couldn't understand. It was 40,000 spreadsheets, and there was no format to it. We went back, we finally got it in the format we wanted. It never ended. So we ended up getting that, and we identified the money they were stealing. They immediately came back and said, look, let us write you a check. And we said, no, we can't trust you now, we can't trust you later. So we went and got another PBM, a transparent PBM, and you'll hear from some PBMs talking today. We're not leaving, I mean, you're going to hear from those guys. And they came in and we saved $1 million our first 12 months out of the hatch by switching. Because Blue Cross Blue Shield came up with a new rule that said any employer, I don't know if it's in place or it ever was a rule, but we were told any employer that had over 1,000 employees could carve out their PBM, and we don't have to use the one they recommended. So we got to choose our own PBM, transparent, and we saved $1 million. So very similar to Medicaid, except I'm an employer telling you the story that way. And because, and let me refer to this slide here real quick. We have found, and this study is extensive, they've gone all over the United States saying, the ones with the real extensive PBM reform, what are you doing with premiums? What are you paying for premiums? Because we're being alleged that it's going to cause premiums to go up. This slide clearly shows that the people that had more PBM legislation and reforms and just kind of rein them into to where they have to play fair, their premiums actually were lower. They weren't higher. So that graph is extensive research that proves that. They will not show you an opposite graph that has any numbers. We begged for them last year. We couldn't. Nothing to do the similar. So then now I'll kind of finish up before I hand off to Kathy here. It says, as a pharmacist, I've watched as patients who have visited my pharmacy for years leave because they've been forced to use the pharmacy the PBM owned. Taking the ability for them to use their local provider who they trust so much. And I think through COVID and a lot of other things, our local pharmacists have become critical, if they weren't already, but critical components of the healthcare system through vaccines, through various other things. Trusted individuals, and now they're being forced to go to these PBMs. And they walk into the pharmacy and they're just devastated when I have to tell them, I'm sorry. You can get one fill here, but after that, you got to go to this mail order pharmacy in North Carolina, and we never see it. And when they have questions, it's just horrible. I've had patients bring in thousands of dollars of medications they can't use because the mail order pharmacy won't stop delivering the medication. Literally, it just keeps coming. They try to call and stop it, it just keeps coming. Or because they aren't sure even how to use it, and they'll just drop it off at my pharmacy. And I'll have to call and try to figure out how to get it stopped. But the most difficult situation is when a patient can't afford a medication, and even though there's a cheaper generic version on the market, the PBM requires the patient to purchase the higher cost medication for no other reason than to generate higher profit for the PBM. Think about that a minute. That happens. We can solve this problem through legislation. We really can, but we know that passing such legislation is difficult. You guys, you get so much conflicting messages. So many different people telling. This affects a lot of people. I mean, you literally got the biggest insurance companies in the world, the top Fortune 500 companies in the world, PBMs, the three major ones that control 70% of the market, are all top Fortune 500 companies. You know, and it's a deal, and I understand how much, you know, but you'll see as we keep going here. We can solve this problem through legislation for sure. Today you're going to hear from a drug pricing expert, national expert, non-traditional PBMs. They'll be here today who will explain what employers that they can save money through PBM reforms, not just increase, but save money. Additionally, you will hear from patient advocacy groups today that will discuss the impact PBMs have on patients' ability to afford the medication. So for decades, legislators at the state and federal level have sought to reduce the cost of medication. To date, these policy changes have not dealt with the comprehensive negative behaviors of PBMs, and I put emphasis on comprehensive. Needs to stay a comprehensive bill. It doesn't need to be pieced together or pieced apart or grabbed and said, let's do it this way, let's do here. You all will be dealing with it till we all retire. We can take what we learned from SB 50, we really can, and use that same comprehensive approach. This is an issue where we can make a difference in the quality of life of every Kentuckian. The PBMs will tell you these reforms will increase the cost of health insurance, and we just got over that. We've done some good things on PBM reform over the years to help our constituents, but we can and must stay with this whole comprehensive thought. I won't be here next session, but urge you to make comprehensive PBM reform a priority. Kentuckians pay the second highest annual average prescription drug costs in the entire country. What more can we do as a body than to address this, really? We've already just seen that we made the adjustments of Medicaid, and it's $500 million. Patients cannot afford to wait for them to be priority. It's got to be patients over profit. It just has to be. And unfortunately, the three main guys that control all the prescriptions in the world are all answering to stockholders. And you'll hear more about that today. Now let me introduce, I'm sure y'all are tickled to that. Now let me introduce Kathy Hanna, chair of the Kentucky Pharmacists Association, who works as a pharmacist at Wheelers and also works for the American Pharmacy Service Corporation. Kathy, and you're going to have to holler like I do.
Good afternoon, and thank you, Chairman Alvarado, Chairman Moser, and committee members for the opportunity to speak today. My name is Kathy Hanna, and I'm here today as the chair of the Kentucky Pharmacists Association to speak on behalf of pharmacists across the Commonwealth and for all the patients in the communities we serve. Representative Shelton, thank you for championing PBM reform in Kentucky. This is an important issue and something that needs immediate attention. The proposed legislation you'll hear about today will address a growing problem impacting all Kentuckians and the pharmacies they depend on. It will help Kentuckians access and afford the medications they need at the pharmacies of their choice, not those dictated by insurance companies and PBMs. Most importantly, the legislation you will hear about today will prioritize people over PBM profits. While the role is unknown to most, PBMs play a significant role in what Kentuckians pay for their prescription medications and where and how they can access these medications. And while they claim to be working on behalf of both employers and patients, more time than not, their actions show they are more interested in their own profits over what is best for employers or patients. As three, what you could call super PBMs, have come to dominate the market. Right now, they control almost 80% of it. The out-of-pocket cost for our patients has skyrocketed, while their access to medications and choice of pharmacies has plummeted. Something must be done before neither patients nor pharmacists can afford it much longer. I commend the General Assembly for passing Senate Bill 50 in recent years. Reforming PBM's behavior in Medicaid was a major step forward. We took a comprehensive approach to the problem, ensuring that the state and taxpayers receive the savings while at the same time ensuring that the patient continues to receive care at the pharmacy of their choosing. While you're waiting on the final report, we have initial indications of the potential savings, as referenced by Representative Shelton, and I'm confident taxpayers will be pleased with the results. With Senate Bill 50, the General Assembly removed the games, lifted the veil, and allowed pharmacies to receive adequate reimbursement for dispensing a prescription drug. But that was just one piece of the puzzle. States surrounding Kentucky have passed comprehensive PBM reform legislation like that proposed by Representative Shelton in the 2022 session, and it's time for Kentucky to do the same. As the slide references, the bill Representative Shelton proposed would ensure that patients have access to care at their local pharmacy, ensure that patients have choice in where they go for pharmacy care, and protect the free market by ensuring robust pharmacy competition. Specifically, the legislation would prohibit PBMs from requiring patients to use a pharmacy they own or are affiliated with, and would prohibit charging a patient a higher out-of-pocket cost if they use a pharmacy not affiliated with the PBM. The bill establishes fair and transparent business practices by eliminating spread pricing and prohibiting PBMs from paying the pharmacies they own more. Finally, the bill would ensure patients benefit from the prescription rebates. Ultimately, our reason for joining the pharmacy profession is to serve patients. And one of the ways we serve them is keeping an eye on the actions of the PBMs and advocating for better policies to defend the needs of our patients. Our Commonwealth's nearly 500 community pharmacies play a vital role in Kentuckians' health care and are often the most accessible and trusted providers for many patients. In fact, 90% of Americans live within 5 miles of a pharmacy. Our pharmacies in communities large and small across the state provide invaluable personal services to Kentuckians, something no PBM or health plan mandated mail order pharmacy could ever do. During the recent pandemic, pharmacists provided countless patients with vaccinations, testing, and treatment for COVID-19. We also answered questions and took the time to talk to our patients about their health concerns. Again, something no mail-order pharmacy could ever do. We know that you have heard from pharmacists about the impact of PBMs on our industry and our patients, but we also want you to hear from those outside of the profession who understand their impact, and from those directly impacted by pharmacy care as well. Thank you in advance for listening to the presenters today. It will cut through the noise and misdirection of the insurers and the PBMs. Thank you.
Thank you very much. So we're going to take a pause here and take on a few questions if folks have any. I'll start off if y'all want to flag our staff and let us know if you've got some questions. Very good. You mentioned the letters we've gotten in opposition. I've seen those letters. I know last year this kind of got derailed because I think those kind of letters went out to our big employers. And frankly, our insurance companies that manage a lot of health insurance, or mostly health plans, I should say, not so much insurance anymore these days, but if they do these health plans, they put out these letters and scare everybody saying the cost of your health care is going to go up. We hear that every year about everything that we propose. And whether or not we pass something or not, the costs keep going up nonetheless. I've gotten to the point where I don't believe, I'll be perfectly honest, just from my own personal standpoint, I don't believe those letters. I don't believe the claims anymore. I don't believe that, hey, you're going to do this, it's going to cost you more. I don't believe it. We heard it all with Senate Bill 50, as you mentioned, and we're looking, and we've heard testimony this interim, $480+ million saved just for Medicaid. That's 36% of our health care that's covered in the state go to people that receive Medicaid. That means the other 64% either don't have insurance or have private insurance. Most of them have private insurance. So I can only imagine the amount of savings that's present in that people are unaware of. We hear people complain all the time about, I have to pay for medication, it keeps going up, or how come my copay went from $5 to $50 to $150? The lady who cut my hair this morning, as I was telling her we were going to be hearing this today, had that complaint for the exact same medication. There's a lot of palm greasing that goes on behind doors with insurance companies and pharmaceuticals, and I've often said, why don't we just go to a straight voucher system where you have a diagnosis, tell me how much you're willing to cover, give me a voucher for that amount, and let the doctor and the patient determine that. If pharmaceutical costs are too high, pharma can determine if they want to sell their drugs, they better get it below that price point or they're not going to sell any drugs. Simple, free market. When I've talked to some people within the industry, they act like that's really novel. And I said, it's a really basic, simple system of how we do this, and you can control your costs and your risks and your exposures. And I think we're tired of it. And so when the same complaints, as you've said, have come with Senate Bill 50, and we heard the same complaints, it's going to raise the cost of Medicaid. Even the cabinet said, we've been hearing from them, you guys want to do it, go ahead, legislature. If it costs more, it's going to be on you. And then they come and go, boy, almost $500 million in savings from Medicaid that's coming down the pike for us. So I think if we have members, we have a lot of friends who represent these insurance companies, friends that I know, who send me letters, and I like them and they're my friends. But I know that the people behind those letters, ultimately, I don't trust anymore with their claims. And we've got people, unfortunately, in the General Assembly who listen to those individuals and say, well, they tell us this. I would argue they're not believable anymore on those claims. And it's time for start looking at something that's going to help protect it. It's going to help reduce the cost. And I'm hoping we're going to get an idea, and I've asked you all to present something on where the dollar goes. When you go to a pharmacy and you give $1, how much of that goes to the pharmacist, how much of that goes to pharma, and how much of that goes towards a PBM. And I think we're going to be shocked at seeing some of the information that's coming through. But we got to start opening up our eyes and stop worrying about relationships or people that we think and start protecting the people of this state. Because it's a huge expense and it's a huge cost on health care for folks that are out there. All right, a couple of questions we have. Senator Berg.
Thank you, Mr. Chairman, and thank you, Representative Sheldon, for being here today and for tackling this issue. I don't know if you remember, when I was first elected, this is one of the conversations we had in the hall, because this is not only a patient care and delivery service issue. This is how do we utilize our healthcare dollars efficiently and effectively and take care of people. So I just want to say thank you, and I want to add just a few words. I was raised by a surgeon who would be about 105 years old today if he was still alive. And, I think he groomed me. But as a young child, I was taught, if you have questions about medications, you go to your pharmacist. They are the experts. They know the interactions. They know the efficacy. They can make you a better doctor and protect your patients. And then all of a sudden, it's like the world decided that all a pharmacist does is put 30 or 90 pills in a bottle and put it in the mail and you're done. And that is not the case. That is not true. As a physician myself, I have fought with Express Scripts over and over and over, because either you end up with 100 too many pills in your cabinet and you're like, why do you keep sending me these? Why do you keep sending me these? Or you don't end up with the one that you really need, and they have no recourse for you, nothing that they are going to do. I have talked to their dispensers, I've talked to their pharmacists. And I'm an educated consumer. We are putting people in danger when we take pharmacists out of the local community as trusted healthcare providers and expect people to rely on whatever some company that doesn't know them and doesn't care about them and is making nothing but a profit on them to show up in their mailbox. So thank you.
Thank you, Senator. Senator Meredith.
Thank you, Chairman Alvarado, and thank you, Representative Sheldon. I want to congratulate you on getting House Bill 457 as far as you did. I had House Bill Senate Bill 134, which is kind of companion bill to yours, which in essence would give 80% of the rebate back to the consumer at the point of purchase. And mine didn't even get out of the gate at all. So congratulations on your ability to move legislation forward. But what's interesting about this, the graphic we saw this morning that you addressed said we would increase costs $3.48 per member per month. If my bill had been passed, and you got a whole lot more layers to your legislation I had in mind, mine deals strictly with the consumer at the point of purchase, but as a community pharmacist, Do you think the savings to the consumer would far exceed that $3.48 per month?
There's absolutely no question in my mind that it would. And to put this in perspective, I think Senator Alvarado mentioned it, that our premiums and our drug costs under the watch of PBMs over the last 20 years, what has it done? Drug costs has soared, but they're in control of it. If you ask them what they do, well, we keep your drug costs down. We do these great deals with the manufacturers, right? And that's what they tell us. And all you got to do is look at a graph for the last 20 years, and it's like 100, 200% increases in drug price. Premiums, same way. Premiums the last decade have gone up 50%. I mean, it's crazy. And they want to stand on that ground. So I'm going to tell you that the 348 represents a 0.6% increase at 348 per member. They try to put it in dollars and add a bunch of stuff up, multiply a bunch of stuff, try to make it look something. It's 0.6% increase in premiums. Now, when the actuary came back with that, I argued with him. I said, tell me about the 0.6. I want to know where you got that from. And clearly on the fiscal note, and I'll give everybody a copy, on the mandate, on the health mandate, it says on the 348 mandate, at the bottom it says, well, we really can't say for sure it's 0.6. That'll be the most it'll be, 0.6, the most, because we really can't get the data. Can't really get all the data we need. Well, you heard me a minute ago talk about how hard it is to get data from a PBM. I tell you what, I'd love for anybody to stand in this room that can get it and understand it and put it in a format that we could understand it. Took us forever as a big company. So, yes, we can get that back. I don't think it goes up at all, but we have we did the local mandates and the fiscal notes, and the fiscal notes came out as zero.
Personally, I don't think you need the data because that just makes it intentionally complex.
Oh, yeah.
I call this an emperor's clothes moment.
Mm-hmm.
We saw a graphic back in the interim when we were in northern Kentucky, and the numbers are rough here, but insulin price $400, the cost to produce it, like $120, and the difference is the rebate. Who's funding that rebate?
Of course, we are
Exactly.
as consumers, and if as part of this comprehensive bill, a big part of that is your bill. And actually, when you wrote it, you remember we had a discussion. We made sure we wrote it to be companion bills, and pulled some of my rebate language out of my bill because I believe so much in what you were doing, and that should be part of this same bill, that whole rebate language. But basically, whatever rebates are happening should be passed directly to the consumer. That's part of this bill, and I think everybody in here believes that. A cost plus, you'll hear from PBMs today that are going to be using what they did when they started, cost plus a fee, and you make millions of dollars, just maybe not enough for Wall Street, and maybe they'll drop out of the Fortune 500. I don't know. I hope not, for their sake. I mean, I want everybody to do well, but not on the backs of our consumers.
Well, no one in healthcare should make a fortune off the misfortune of others. And what killed my legislation was that doomsday that it's going to just wreak havoc for everybody. But in fact, we're asking for money that belongs to us to begin with because we're paying it, and it's
that's right.
It's exaggerating the cost of medicine. So
that's right.
But
thank you,
Mr. Chair.
Thank you, Senator. If you take a look at $482 million that we have on page 1 of your presentation there, and there are 1.6 million recipients of Medicaid currently in Medicaid. Just take a look at that. That comes out to $301.25 per person if Medicaid were a private plan. That's what we would have saved this year. So that gives you an idea of, and you can imagine the other 2.9 million people in the state that are receiving health care of any type. You can extrapolate it and see the kind of savings. Next, Senator Kerr. Oh, very good. Thank you. Senator Weiss.
Thank you, Mr. Chairman. Representative Sheldon, thank you so much. Going to miss you in this arena, in your passion and all the help you've given me and others when it came to PBM legislation. Kathy, good to see you also. Yes, there's many of us. There's pharmacists here on this committee and others that have worked hard with 50, 117, all the stuff we've done in the past, and I appreciate the efforts, but you're right. We see other states around us that are passing more of a comprehensive plan, and this is something that we have got to address and not continue to go another session without doing so. My question, and Kathy, you may be the one to answer this, what about the federal level? what are we seeing with our federal delegates in U.S. Congress of trying to handle this situation? I think every state is doing all that we can, but your conversations with our U.S. Congress members, U.S. senators, and others, what are we seeing or what are we not seeing to also engage them in this arena? Because I do appreciate leadership that have allowed other bills to move and have tried to progress, but at the same time, we go after this every session upon every session, and so we need help also at the federal level.
Yes, as many of you all may know, you do see the bills being, introduced on the federal level to try to address many of these issues. And also, if you've been watching, the Federal Trade Commission also had some hearings recently. So there are some activities on the federal level. I think you may be able to answer this, they're probably hitting some of the same, getting a lot of the same information from people. And so the sooner we crack that open, the better. But yes, there's a lot of activity out of, is it Carter? Wait a minute. In Georgia?
Yes, well,
And
really,
just recently, I
yeah,
saw.
I think federally, and I don't mind jumping in,
Yeah,
just like
please.
federally, they voted 6-0 unanimously to investigate thoroughly PBMs just recently, just in the last few months. That's a huge, and that should just tell you how how concerned everybody is. Our concern. Now, this is going to go on forever. And, of course, Federal Trade Commission, they look at it much broader situation like unfair practices in the marketplace, monopolistic type, manipulative type practices. They will look at it from a broader lens. Where are the providers? What kind of base do we have? How vertically integrated are we at? They'll come out and they'll talk about, well, let me see here. These PBMs, they used to be kind of separate over here a decade ago, but now they have migrated and sucked themselves in, and now they own the insurance companies, or the insurance companies own them. There is absolutely no protection. We have the PBMs setting the prices, negotiating the prices, and they are performing services for insurance companies they own or don't. The top insurance companies are owned by the PBM. So this vertical integration, and just recently they bought another company called Change, which was the last company I know of. It used to be called MDON, used to be called NDC before that, Relay Health before that. Got to go back a ways. That company switches every prescription transaction in the country. It's called Change Healthcare. And just recently, United Healthcare just bought them. And the Federal Trade Commission was investigating that one as well. So there's just a lot going on, and this vertical integration is what the federal guys will address.
Thank you. And it's always important to note that our federal partners often look to the states to start the experiments of making the change that needs to happen. So often, if we're willing to take the lead, they'll often follow. Representative Moser.
Thank you, Mr. Chair. Thank you so much for bringing this bill, your work on it, your persistence. I really appreciate it. We are really going to miss your passion and your expertise. So thank you for continuing to work on this. I just a lot of what I wanted to talk about has already been addressed. I did have some questions about what on a federal level is being done to address this. I mean, we hear bits and pieces. I know that there is legislation that's been proposed, and it's good to kind of keep an eye on that. I'm looking at the flyer, the copy of the flyer that was part of our letter this morning, and I'm just a little bit amused at some of the comments. We're talking about the vertical integration and how that absolutely creates a monopoly, and so there's a comment here that says that this bill would give hospitals a monopoly on certain drugs. I guess this is talking about specialty pharmacies or what white bagging. I mean, to point out a monopoly is, I mean, when that's exactly what we're talking about here, and the ways that it prohibits the free market, and it just creates an absolute level of bureaucracy that is we can see easily through Senate Bill 50 and what that did to save money through Medicaid. What this is likely to do for other coverage. Do you have data from other states? Have any other states introduced this or similar legislation? And what are you seeing from some of the other states?
I have looked, just to, for instance, in the last, I've been working still, last 3 months, there's been 10 pieces of legislation passed in the United States, various states, Tennessee, Colorado. I can't go through them all, but I looked at them thoroughly. Oddly enough, sections of our 457 are in most of them, if not all of them. That's great. That's great. They are doing it because of the results that we've seen in studies that have come out. So as individual numbers from different individual states I don't have, but the graph we showed earlier was, there has been extensive study on those that had extensive PBM reform. And just with, and they tried not to, and I like that they did the study this way. They said, look, we're not going to really even try to press down on what reform you're doing. We just want to see the ones that have the most reform, and let's see what their insurance premiums are. That put up the most rules in front of PBMs and say, look, you can come to play, but you just need to play fair. That's all. It was, a lot of people like to quote Milton Friedman and say, he says exchange of goods and services, free market capitalism, that's what it's all about. We all believe in that. But the end of that quote, if you go look at Milton Friedman's quote, it says, as long as everybody plays fair, as long as it's fair or plays fair, or if the exchange of benefits benefit both people. They don't want to quote the rest of the most famous capitalists in the country, or in the world, who's passed now, but I read a lot of his books. I really do believe it's beyond the point of wondering whether it's going to help or not. But to answer your question, we have large, extensive studies that show premiums went down, and they refer to, causing, hospitals having the ability to have a monopoly on certain specialty drugs. That is almost laughable, really, because you send a little lady, Miss Jones, who's been coming to me for 30 years, and now she can only go to North Carolina to get her mail order. And, you go through enough of that, and, it's tough. So thank you for bringing that up.
Absolutely. And if I may just make one more quick comment, hopefully, back to the flyer that we have, I'm reading through this, interjects state government into private contracts, puts government in charge of your health care. If anyone here thinks that government is not already in charge of your health care and all of the regulations that we all deal with, you've got, I guess your head is buried somewhere in the sand, because and what I see as very important about this bill is this is a consumer protection. That is our job as government employees and legislators to protect our consumers, to really work hard to get the cost of drugs down. This deregulates this system, if you will, and untangles this level of bureaucracy, this layer of bureaucracy, which we are seeing is completely unnecessary. So, healthcare is very complicated. I think we can take this one step to really make it less complicated. It's virtually impossible to untangle, but we're working on it. But this is an important step. So
thank you very much. And I'll just say that, I've heard the argument on that about messing with private contracts. That absolutely blows my mind away. If you understand healthcare at all, you understand how many regulatory. We can't charge certain services that you do. We can only charge a certain amount because it's controlled, okay? And we can't do certain things. And then before we can do this service, we got to do another service to get to that service. You know what I'm talking about. And this is all controlled by the government. And since 2010 and Affordable Health Care Act, we have had a lot of control of our government. And, we all were told we were going to have hospital choices and doctor choices and all that. It took a long time for that to come around and us to get that put to where we got more choices. So that's what this is all about, and thank you very much for bringing that up. Thank you.
Thank you. Senator Givens.
Representative Sheldon, thanks for your passion on this legislation. We've had multiple conversations about it. I want to start by complimenting our co-chairs on gathering us today, putting legislation in front of us that's been much talked about, and giving us a chance to have these sort of conversations. I think all members have a copy of House Bill 457 in their packet. Do you have a copy there handy? If you don't, I'm confident staff can provide one for you, and I would ask them to do so if they would. So, Representative Sheldon, as I look at the legislation, I'll be moving quickly through it because, again, I love the interim being used to talk about legislation. Section 1 looks like primarily existing language. We're making a few changes to existing statute in 304-17A through 164. Health plan meaning. When we use the word insured there at the bottom of page 1, help us to know who is impacted by the legislation. Is this all insurance providers in the Commonwealth, meaning private and the MCOs and everybody? Turn your microphone on, please.
Thanks, Senator Gibbons. We intend for this legislation to affect all PBMs that do business in Kentucky. So anybody that would do business with prescription coverage is going to be affected by this in some manner.
So whether you're an MCO providing services to privately insured or an MCO to publicly insured, your insured means everybody that is an individual enrolled in a plan who receives services. The next page, when we look at PBM, we're defining the PBM space to mean what you say here, which actually changes. And I don't think there's a big difference between the 304 reference and the previous 304-17A, the 304-9 and 304-17A, because current statute is 304-17A provides a definition. We're changing it, but I don't know that there's a big difference. Do you know of a reason that we're changing it from sub 17A to sub 9? Pretty deep in the weeds there. But
that's okay. What line are you on, 15?
So I'm looking at line 19.
19.
We have a strike through of 304-17A,
Right.
and we're changing the reference and definition of PBM to 304 as indicated on line 15.
Yeah, right here.
And I don't know if there's a big difference. I'm just seeing it there and wondering.
You know, I think our goal here is when we're writing complicated
Sure.
Legislation is that we stay consistent.
Okay.
And I think
so you
that
think it's a consistency matter.
I think it's a consistency
Okay,
issue
talk
because
to me.
throughout the
Sure.
go ahead.
On the consistency question, talk to me about the carve out here, where we say it means this, except it does not include a PBM contracted by and acting under the direction of any hospital or health system that provides a self-insured plan if the hospital or health system owns a pharmacy. Help me to understand that.
That came about towards the end, but now I want to preface these answers, and we can go on through the whole bill if you want, by saying that I feel like this version is exactly the kind of comprehensive legislation we need. There'll be some changes along the way. That came up potentially, and we inserted it towards the end of writing this bill, because we realized there could be some effect on federal dollars that were coming in. Where we put the exception is hospitals that have their own pharmacy that it's administering their own plan, and they were doing their own thing, and then they have federal dollars that are also coming in. We were able to identify that there may be some issue in federal dollars coming in if they were included. Rather than me get into the deep weeds with them, I went back to them and just said, look, we're going to pull you out. Anybody that gets government dollars subsidized, that it could have some effect, and then we can talk about what effect that was later if you want. But that it was clear to me that I didn't want to fight that fight
Right.
now.
So the
or
federal
at the time,
the federal money that flows into
hospitals.
the hospitals, we don't have the same concern about the federal money that may flow into the MCO space, though.
No, they never explained to me any concern, and I'll
Okay.
be honest with you. From a state position, I was concerned about the federal dollars that, almost looked at it like the managed care issue with Medicaid. I wanted to make sure that when they said, it could affect how much federal dollars we get. The MCOs have not presented such an issue for
Okay,
me. So there's something there that's different.
So toward the bottom of page 2, we run out of old language and we start with entirely new language on page 3. And it looks like the rest of section 1, mainly the new language. Share with me the goal. Is this a level playing field concern about mail order pharmacy as it
What
impacts
section is this?
local pharmacy? I'm on the top of page 3.
Right.
And we started a lot of referencing to mail order pharmacy distribution. Is that a level playing field concern? Is that what that is?
Yes, what it is they're mandatory. It's not that people can't use any mail order or any pharmacy they want. We don't want to take patient choice away. What this simply does is says you can't force a patient to go mail order to your pharmacy that you own, or force them to go anywhere. You should make an option. In our own health
Right.
plan here in the state, we have an option, but you have to opt out. That's how manipulative this
So
gets.
that's the goal of that section. Mr. Chairman, I don't want to belabor, but if I could have just a little bit more latitude, I'll try to be brief.
Sure.
Thank you. So section 2 looks like primarily definitions, but it's a lot of new language. In fact, all of section 2 is new language.
Right.
Definitions form the crux of what the legislation actually does. So I don't have any major concerns, but that's a definitional sort of section. Section 3 at the top of page 7 is where it starts. It looks like we're requiring PBMs to register. Share with me the goal about registering, and there's a network adequacy piece based on my read through just a moment ago there on lines 10 through 14 and maybe even higher, maybe 6 through 14. So we're going to register them, and then we're also going to make sure that they are adequately connected. Is that what we're doing?
Accessibility certainly means that we found when they start mandating these things and saying, well, we're going to handle your prescription process, but you've got to go here and you've got to go here. Many times where they were being forced to go, whether it was mail order or even another preferred network where there's a pharmacy 30, 40 miles down the road and there's a local pharmacist 2 miles across the street. So we addressed accessibility because of that very issue. The network, the rest of it is more stuff that they have to file to make sure they have an adequate network. They have good things. So, what was the second part of your question, or is that it?
I think that was mainly it.
Okay.
The registering part is new, and I think you're simply wanting to have the commissioner determine that the network is reasonably adequate and accessible based on the definition up above. So I think I understand your goal there. I'm on the top of page 8 now, and I'm moving quickly in respect for committee members' time.
What section are we in?
It looks like section 4 relates, based on my scribble notes here, to be PBM interaction with and payment to pharmacies. So there's a lot of concern, and this is, I think, would you say this is the heart of what you're doing, is this payment methodology that, boy, oh boy, I came here 12 years ago and never had heard of MAC pricing and all the other stuff that's involved in the swirl of this until Senator Wise introduced it all to me. And boy, oh boy, what a learning curve that was. But I think this section 4, as I'm trying to understand it, you're going back at that question of interaction with and payment to pharmacies and the PBM, and that.
Well, there's a lot of sections in this bill. This particular section, I wouldn't say it's the heart of the bill, but it certainly is a big part of the bill. As you go through here, in order for the consumer to be serviced properly, it's going to have to come through the pharmacy. And to come through the pharmacy, there has to be network accessibility and everything else it takes to get them to that local pharmacy. So we put in there fair contracting provisions. We tried to put things like, and that's, you probably heard this nationwide, but let's just boil this section down to what needs to happen and what for sure needs to happen is the charge that the consumer has to pay needs to be what the charge is at the point of sale. It doesn't need to come back retroactively and end up something else. Currently, as much as 40% of some prices that a consumer pays is clawed back in some degree 3-4 months later by the PBM saying that they're trying to get some ratio put together. They couldn't determine the cost of goods at the point of sale. So
Clawed back from the pharmacy?
yeah, from the
Clawed back
pharmacy. Yeah, the consumer is actually paying higher in their donut hole because of these practices.
So,
Well, gentlemen, I'm going to cut this off of these conversations.
I'm
We've
sorry.
got a very long presentation where you're going to see a lot of these abuses very clearly. I think
Okay.
through a presentation.
Yes.
And I know we want to get in the weeds on some of this, but in the interest of time, we're almost at 2:00 already, and we've got to know a very long presentation coming up as far as what we're going to see from some of our PBMs, MCOs, and what goes on. I really want to see where the dollar goes from the point of a consumer going to the pharmacy and where that money goes. I think if we see some of that, it'll have a better understanding of why some of what we see is in this bill.
thank you for the latitude that you extended to me on that. Thank you.
Absolutely.
Yep.
Thank you very much, Representative Kathy. Thank you all. I think we've got some folks that are presenting. Some are remotely, is my understanding, correct? Just one person remotely. So those who are here, I understand. I think we have Antonio Chacha. I think he's online. And we've also got, I believe, Josh Golden, Justin Joseph, Fred Barton also. If you all would like to come to the table, and please introduce yourselves to the record. Now we have getting a bit tight on time, so if you can, I know you've got a bit of a lengthy presentation, so if you can, I would urge you keep this within 20 minutes, and that way we have a little bit of time for questions also from members who might have some questions on things. And again, whenever you're ready, please introduce yourselves and begin your testimony.
Good afternoon, everyone. Justin Joseph, pharmacist. I'm a senior director for PBA services at Capital RX.
Good afternoon, everyone. Josh Golden, Senior Vice President of Strategy with Capital RX.
Good morning. Fred Barton. I'm VP of Account Management, pharmacist with Imsana RX.
Hello, my name is Antonio Chacha. I am the president of 3 Axis Advisors and the CEO of a nonprofit called 46 Brooklyn Research.
Thank you so much. Thank you for being here. Please begin your testimony.
Thank you, Senator Alvarado, to the chairs, to the members of the committee. Thanks for the opportunity to speak with you today. As I said, I'm with Capital RX, which is a PBM, but we're going to explain how we are a fundamentally different PBM within this rather opaque and complex landscape. A little bit about me to provide some context as to why I felt the urge to be here today to speak in support of PBM reform legislation. I spent the past 20 years prior to joining Capital RX as a consultant working with some of the largest, most complex benefit plan sponsors in the United States. These were Fortune 100 companies, labor unions, municipalities, county governments, state governments, et cetera. In that capacity, I was a PBM expert. So I helped them with the procurement of PBM services, implementing new PBM arrangements, negotiating contracts with PBMs, and auditing those PBMs as well. This provided me with a really unique window into the business model of the typical PBM. After 20 years of this, I would suggest there's probably 200 people in the United States that fully understand from start to finish how PBMs derive their profitability. And of those couple hundred people, there's probably a handful that would be willing to get up and testify in a public setting as to what some of the problems are with that model. I happen to be one of those people, which is why I'm proud to be here today to share my expertise with you and my experience and what I've seen in an industry that is fundamentally flawed. About my current company, Capital RX, I'm joined by one of my colleagues from our organization as well, Justin Joseph. We are by no means a typical PBM. We were founded 3 years ago by a group of drug supply chain experts. We're based on a really simple principle, right? It's that in order for a PBM to act in the best interests of patients and plan sponsors, their financial incentives must be aligned and they must operate in a transparent manner. Now, when I say aligned, this is easy. No conflict of interest. There can be no inherent conflict of interest in the way the PBM does business. And when I say transparent, I know that word is used quite a lot in the world of healthcare. But in the world of pharmacy, it's simple. Every drug should have a price. That price should be visible to everyone involved in the transaction. And it should be auditable, right? There should be a paper trail. Unfortunately, most PBMs in the industry do not operate on either of these tenets. They they, they sit in a very unique position within the supply chain. They are a financial hub, which puts them in a position to derive hidden profitability from a vast array of complex and opaque financial relationships. I think Senator Givens and others have sort of hinted at the inherent complexity of this, that it can seem overwhelming to someone who's sort of new to this industry. And I grant you that. It is, at times, seems almost intentionally complex. And the way, it would probably take me, a 10-hour masterclass with you all to go through the entire range of profit sources that the PBMs rely on, how they hide those profits, how they derive those profits, and what portion of the dollar breaks up into each of those profit pools. And so instead of you dragging you through all that, I'll try to summarize some of the key elements of the PBM model that are broken. Number one, the use of proprietary price lists to manipulate the cost of drugs. We referenced MAC lists earlier. This is one example of that type of list. This is the PBM acting as price manipulator, right? And in essence, managing two different price lists, one that they reimburse pharmacies and one that they charge patients and plan sponsors. Those two ledgers do not have to match in the current ecosystem. And it's between those two ledgers that the PBM can hide what's commonly referred to as spread pricing. PBMs will steer patients towards profit-driven mail order and specialty pharmacies that they own. We casually refer to this as steerage. This happens even if the patients may be able to obtain those drugs at a lower cost, perhaps locally at a retail pharmacy. And they quietly retain millions and millions of dollars in rebates from pharmaceutical companies. Unfortunately, the media and the forward-thinking government officials such as yourselves are starting to shine a light into the black box that PBMs sit in, and we applaud that. We're one of very few PBMs, I think, that would stand up and applaud that effort. This is because we are, in a nutshell, a successful case study. Our organization is a case study of how you can do business differently within an entrenched, opaque industry like PBM. I'm going to explain how we do that because I think it presents a model upon which you may wish to consider as you work to craft and refine PBM reform legislation. But at the heart of it all is no spread pricing, a full transparency and pass-through around the rebate revenue that we receive on behalf of patients and plan sponsors, and our entire retained revenue isolated to a fair admin fee that's out on the table for the client to see. This is truly the epitome of a cost-plus model. Now, I know that there is a pretty common sort of straw man argument that comes up from the traditional PBM market, that bit of a scare tactic that talks about the move to transparency having an increasing impact on the cost of care and premiums for health plans. I refer to this as a straw man because we've got a lot of anecdotal evidence, a lot of data within our own book of business that frankly proves this flat out wrong. Okay? We are a fast-growing PBM. It is because of our model. It's a testament to the fact that this is where the industry wants to go. This is where plan sponsors largely believe they should be going. We have over 180 clients on board. We service over 1 million lives, 1 million member lives, patients that we care for as part of our service offering. And as those clients came on board, one after the other, we saw a consistent pattern. Now, the vast majority of these are coming from large, established, traditional PBMs. The pattern we saw was clear. It was a decrease, invoice to invoice, in the costs that they were incurring, an increase in the rebates that they were receiving, and a total reduction in net cost. Now, it varied from client to client, right? But the range was between 15 and 25% was the typical range. That's a invoice-to-invoice cost reduction from year over year. This is meaningful. This is helping plan sponsors maintain a sustainable benefit. Now, I want to be clear, we're not anti-profit. We're a for-profit company, okay? What we are is a company that acknowledges that how a PBM makes their money can impact their behavior. Let's look at a quick example of that. We talk about the retention of rebates, right? Well, PBMs retain some unknown portion of rebates, and part of that is veiled in obscurity, right? It's hard for us to even discern what a rebate is for a given drug. PBMs will at times stand up and say, well, who cares, right? We're retaining the rebates, we're using it to offset our administrative costs and thereby charging a lower admin fee to the plan sponsor, right? So everyone wins. Well, what it doesn't acknowledge, what that argument doesn't acknowledge, is the way the rebate retention can influence the way the PBM behaves. And I'll give you an example here with a drug called Duexis, which has been around for a while. Pharmacists may be familiar with this drug. It's the combination of two over-the-counter products, Pepcid AC and ibuprofen, right? Essentially Advil and Pepcid. The active ingredients in those were combined into a single pill for convenience, and that pill was released by a brand manufacturer at a price north of $2,000 per month. I don't know if any of you have purchased Advil or Pepcid lately, but I can stock both of them in my medicine cabinet for under $20 a month. Now, PBMs often say that their responsibility is to their plan sponsor and that their goal is to help their plan sponsor manage costs over time. So clearly, no PBM in their right mind would favor this drug on their preferred list of drugs, their formulary, right? Right. Well, common sense is not so common in the PBM industry. At one point or another, every major traditional PBM has included Duexis on their formulary. This means they weren't only approving it, they were actively steering patients towards this product. Okay, this is an example of pure waste within the healthcare industry and within pharmacy specifically. And it's only one of many examples of products like this that don't provide clinical advantage over an available generic or over-the-counter, and yet PBMs are actively moving market share to these products, not because they're better clinically, not because they're less expensive, clearly. They're far more expensive. They're moving them because they have a vested financial interest in doing so. They retain a massive rebate on the back end of products like Duexis, Vimovo, and other products like that. And so this is a real-world example of how this misaligned profit source can influence the behavior of a PBM and add cost and waste to a system. That's cost that is ultimately borne by patients, by plan sponsors, and by taxpayers. We talked about, some previous presenters have talked about steerage. I want to make it clear, Capital RX is a successful PBM doing business without owning a mail order pharmacy or profiting from the dispensing of drugs. We believe this to be an important tenet. Once you acknowledge that the PBM is allowed to profit from the dispensing of drugs, what you're saying is that it's okay for their profit to be tied to the price and the volume of drugs. Now, what financial incentive does that PBM have over time? Clearly, their incentive is to pursue drugs that have higher cost and to dispense as much drug as possible, as much product as possible, even if it's not of clinical value to the patient. Now, there are a number of other aspects that I could go into. I'm a self-proclaimed geek, if you will, on drug pricing and the PBM industry. Happy to answer questions. I'll highlight one or two sort of nuances that may come up in discussion over the course of consideration of this legislation. One is around NADAC pricing. So NADAC is the pricing benchmark that we as a PBM have elected to use as the baseline for reimbursement to pharmacies. This is a fair acquisition cost index. It's used actually in many state Medicaid programs across the country. It is a tested baseline for drug pricing. And layered on top of that is a fair dispensing fee for the pharmacy. What this does is this stabilizes reimbursement across pharmacies, and it creates a more consistent price experience for the patient. Compare that to the current prevailing system of MAC lists and average wholesale price with most PBMs, and you'll find that that system creates a highly volatile price experience for the patient. Month to month, I know this. I'm on my wife's benefit plan, which is not with our company, unfortunately. I go to get a generic drug one month, it's $30. The next month, it's $75 at the pharmacy. And I've actually confronted my pharmacist about this. And I've asked him, I said, what gives? Why is it more than twice as much this month? The answer to the pharmacist is telling. That's just what the PBM told me to charge you. That's perhaps the sort of biggest absurdity of the PBM pricing world. And that is, if you look at how things should work within a free market, take over-the-counter drugs, for example, right? Perfect example of a free market economy at work. A patient goes into a store, looks for the over-the-counter drug, they pull it off the shelf. There's a sticker price on there. The price is displayed clearly. for that product. That patient can go compare that price against what's down the street at the local grocery store or the other pharmacy across the street. And that pharmacist, that person managing the pharmacy, is held to competitive pressure to make sure that that price is market competitive, or else the patient's just going to go elsewhere, right? That's why over time we see over-the-counter costs go down. OTC drug costs have generally a deflationary trend. Compare that to the experience a member has when they walk 10 paces back and go to the pharmacy counter. Suddenly, it's a roulette wheel. That patient has no idea what they're going to be charged. And here's the other bizarre element. That patient, getting the exact same prescription for the exact same drug as the patient in line behind them, may be charged a radically different price. Price discrimination is what's going on here, and price manipulation. And it's simply because that retailer is not allowed to operate in a free market system because their pricing is essentially imposed by the PBM. So again, under our model, it's cost plus, both for us in terms of how we derive profitability and the way that we reimburse pharmacies. We are a case study example that can be successful in our industry. As I said, our growth is a testament to that, as is the experience that our clients have as they come on board and experience a cost decrease. And so I'll pause there and welcome Jessen to add any comments.
I'm going to have Mr. Chacha go next if it's okay. I think Representative Sheldon would like for him to be able to present. And Mr. Chacha, if you're there, if you'd like to go ahead and be next to present your slide deck.
Absolutely. Thank you so much. It's great to be with you all. I apologize I'm not there in person. I do have a very pregnant wife with 3 other kids at home, so I'm trying to prolong my marriage for the long term. So as I said at the onset, my name is Antonio Chacha. I'm the president of 3 Axis Advisors, CEO of 46 Brooklyn Research. I spent about 10 years at the Ohio Pharmacists Association, where I heard very similar complaints from local pharmacists around the lack of objectivity and sustainability of PBM reimbursement. So understand that my entry into this world is very much tainted by the lens with which I viewed it at its onset. But today, we now do drug pricing analytics because, much like a story that you all are very familiar with in Kentucky, pharmacies in Ohio in 2016 saw severe cuts in our Medicaid managed care program. I went back to state officials at the time and asked them what happened. They looked at me like I was crazy because they were spending more for prescription drugs than they ever had. And voila, we uncovered in our state $245 million in spread pricing when PBMs were paying pharmacies low, billing the state high, and pocketing the difference. That fascinated me. My background was journalism before I got into the pharmacy world, and I found it just absurd that we complained so much about rising costs of prescription drugs, yet we had no idea that an intermediary who's just processing a claim could slap over $6 in hidden markups on the transaction at just one stage of their involvement in that transaction. So I left the Pharmacists Association. I started 46 Brooklyn Research, which is a nonprofit dedicated to giving drug pricing data away for free. Medicaid data, Medicare data, looking at trends with how brand manufacturers change prices annually. When we launched that organization, it was intended to be something that I did between the hours of 9 p.m. and 12 a.m. We were bombarded out of the gate, and so we launched a consulting firm where today we do work for Medicaid fraud control units, government agencies, state attorneys generals, provider groups, research firms, technology companies, law firms, investment analysts, and yada, yada, yada. So let's talk about the field of play first. And I know this hearing is kind of targeted PBMs, but I think it's really important to understand the fundamentals of the drug channel as a holistic entity. And Senator Alvarado, I know you mentioned you want to kind of be able to carve up where that dollar goes. I will throw a little cold water on your aspirations in that it is not that easy to obtain because all of these contracts are in particular programs that have their own private negotiations. And a lot of this is under lock and key, but I will do my best to try and get you to where you want to be, at least as close as I can get you. But let's recognize here that we have 5 primary players in the drug distribution channel. Drug manufacturers sell drugs to wholesalers who sell drugs to pharmacies, who get compensated by PBMs on behalf of insurance companies. There are other intermediaries along the way. Happy to have a wonderful conversation around GPOs, PSAOs, repackagers, rebate aggregators, benefits consultants, but we only have so much time. The thing that I will point out, and I think this is one of the most important things to understand, is that those main 5 pillars we typically talk about as if they are standalone entities. But if you look at the top of the Fortune 50 list, you have pharmacies, you have wholesalers, you have manufacturers, you have PBMs, and you have health insurance companies. And sometimes the same company can be 4 of the 5. So when you talk about, hey, how profitable is this entity versus another, you must recognize that because vertical integration complicates the waters, it can be very hard to ascertain truly what's happening at an individual level, because we're dealing with healthcare monoliths at this time, not just standalone PBMs or standalone pharmacies or standalone wholesalers, et cetera. And while every single member of the drug distribution channel, whether they're smaller independent players, like my good friend Representative Bentley over there, or they are publicly traded members of those drug distribution channels, we have to acknowledge and accept the fact that every layer of the drug distribution channel has a profit incentive. For those that are publicly traded, it is their fiduciary obligation to make more money this year than they did last year, and make more money next year, and so on and so on. This is okay, but it's not because it's wrong. Profit is not wrong, but we have to understand that profit is going to be the motivating factor that will drive drug supply chain behavior. And in our efforts to control prescription drug costs, we must, as Josh just said, have a proper calibration of incentives in order to assure efficient spending and maintain robust access to pharmaceuticals. So let's start with the very, very top. What is the price of a drug? Well, that depends. There are a lot of different ways that drug pricing nerds like myself could tell you what the price of a drug is. And you can quantify price in a variety of different ways at every stage of its drug distribution. And even when you pinpoint, we want to talk about this price, that price may not accommodate for post-adjudication reconciliations, rebates, and so on and so on. And so anytime that you have more than one price for a drug or anything, you have no such thing as price. That's because drug prices in a purchasing perspective are hidden. They are set by private deals, backroom negotiations that don't necessarily lend itself to an inefficient market, and instead ends up creating price discrimination, as Josh just pointed out. Well, it also means that drug prices can be incredibly prone to manipulation. That's where PBMs were brought in. Decades ago, as more and more medicines entered the market and as drug costs ballooned, plan sponsors, rightfully so, sought ways to hold spending accountable. PBMs were brought in first to just do the simple act of facilitating the transaction. But over time, we relied on them more and more to act as a necessary friction against drug makers, wholesalers, and pharmacies, and other members of the supply chain who, as I just pointed out, have a profit incentive. Left to their own devices, we should trust that they will try to maximize as much money as they could get their hands on. So PBMs were brought in as a counterweight to that to help us as payers to try and achieve an equilibrium between access to medications at affordable rates. So as PBMs work to control that end of the drug supply chain, over time, they also began to develop business interests in the very marketplace they were hired to control. So today, PBMs will advertise that they are the only entity in the drug channel working to control prescription drug costs, but data that we have uncovered, data that other state auditors have uncovered, and so on, show that PBMs' profit distortions have become incredibly undermining to their initial charge of simply working to control the cost of drugs, because now they're making money off the cost of drugs. So what we do know is that prices continue to go up on a year-by-year basis. The last few years, we're looking at brand prices go up to the tune of around 5%, 4 to 5% every year. That's list prices, though. If you look at the discounts that PBMs and other intermediaries are capturing on those drugs, you'll actually find that in many instances, net prices of pharmaceuticals are actually going down. Well, it's hard to actually figure out whether or not that's true, because a lot of these deals are, again, behind lock and key. Because these manufacturer rebates to PBMs, insurers, and little-known middlemen now known as rebate aggregators, because they're confidential and vary widely from plan to plan, it's extremely hard to figure out the actual price of a drug. Now, let's not just blame PBMs and insurance companies, because government programs like the Department of Veterans Affairs, state Medicaid programs, because they were required by law to get the best rebates in the market, what ends up happening is that anytime somebody gets the best price, everybody else is paying a worse price. And so patients who are underinsured or not insured end up picking up a disproportionate share of the overall cost, and that includes employers as well. And because each health plan and PBM promotes coverage of different drugs, preferring some drugs over others, making apples to apples comparisons from one PBM reality to another is very, very difficult. Regardless of any of this, there is an extreme inability to objectively determine what a fair price for a drug should be for a conventional plan sponsor. And because of that, we don't have traditional market forces that pressure supply chain margins. And that's because the system is built on fake prices. The list prices for pharmaceuticals are wildly overinflated to their actual cost. PBMs use those list prices, what we in the industry call average wholesale price, but we also jokingly refer to as ain't what's paid. They use AWP as the basis for their pricing guarantees, both when they pay pharmacies and bill plan sponsors. Brand drugs have high AWPs that are offset by essentially $200 billion in concessions that we call rebates, formulary access fees, kickbacks, whatever you want to call them, that actually make the net prices that manufacturers bring in much lower. But generic drugs also have high AWPs that in no way reflect the actual prices pharmacies pay to acquire those drugs. In both regards, the real prices, the actual amounts of those drugs, the real prices are completely hidden from the plan sponsor and the patient. So those who claim to provide savings on prescription drugs are often quantifying the value of those savings based on those bogus, artificially inflated list prices that are born out of the industry dysfunction. And so here's the fallout of that. This is a very simple, old, boring bottle of generic Nexium, where it costs pharmacies on average around $17 to $20 to actually put it on the shelf. As Josh mentioned, they use a benchmark called NADAC. Some states like Alabama and my home state of Ohio, starting actually at the end of this week, they force pharmacies to disclose what they pay to purchase their medications, and then they use that benchmark as the basis for cost rather than allowing the PBM to just invent whatever that price is. When you look at the actual price of it, the actual cost for a old bottle of generic Nexium, again, you're looking at around $20 for a 90-count bottle. Compare that to the AWP, which is the basis of the pricing in the PBM contract with the plan sponsor, you're looking at something that is 47 times more expensive. So it shows you the delta, and there are drugs that are even worse than this, where the AWP is in a different universe relative to the actual cost, yet it is the foundational language of traditional PBM contracting. And so what that enables is gamesmanship of price, or arbitrage, which is taking advantage of the asymmetry of information, buying something at one rate, selling it at another rate, and never disclosing essentially any of the delta in between, and never disclosing the actual cost of what was actually purchased, thus disallowing a plan sponsor to have an objective evaluation of what the value proposition of the service rendered by the intermediary was. Well, that's when we uncovered the $245 million in Ohio, and you all uncovered 120 plus in your Medicaid program. What we found was that those cost-cutting middlemen were marking up prescription drugs to the tune of 31.4% in our Medicaid program. And so after that, our state started suing. Ohio is in the middle of litigation against PBMs over alleged overcharges in our Bureau of Workers' Compensation program, our state highway patrol fund. And many of you are probably aware of the massive settlements that are occurring over the last year with Centene. Centene settled for $88 million over alleged spread pricing problems in Ohio, $55 million in Mississippi, and just last week, Texas settled for $165 million as well. I believe Kentucky is in the on-deck circle at some point as well when it comes to those settlements. But we're talking about the first settlements ever against PBMs and health insurance companies over overcharges in Medicaid managed care programs. This reckoning, this accountability is really fresh, and we're just at the very beginning stages of it because our systems of accountability have not evolved to the degree of the sophistication of the vertically integrated health insurer PBM enterprise. Ohio's not alone. Kentucky's not alone. If you could burn a chart into your brain, this is how significant spread pricing can become. We got data from 450 pharmacies in the state of Michigan, which is reflected by the green line in this chart. The blue line represents the NADAC, and the orange line represents what Michigan Medicaid was charged for the exact same prescriptions over essentially a 2-year period. And as you can see, the cost of the drugs are going down. The pharmacy margins are going down, and the PBM spreads are going up exponentially. That's not to say the PBMs aren't providing a service, but you have allowed them, not you, but payers in general, have allowed them to essentially say whatever the cost of the drug is. Could you imagine how absurd a system would be if we went to Walgreens or Kroger or even an independent pharmacy and said, our system will be designed in such a way that we will pay whatever those pharmacies bill us, right? That would be absolutely absurd. Well, now that PBMs make money off transactions exactly like pharmacies do, you should look at it as equally as absurd to simply pay whatever bill a publicly traded company forwarded you. So let's look at the fallout of fake prices. As I mentioned before, we have really high list price drugs that are offset by really, really big discounts. Well, understand that the exposure to the list price is going to be a sliding scale. Medicaid programs are mandated to get the best discounts in the market. Then you'll have the federal government. They might get a worse deal than that. A Part D plan sponsor, worse than that. A large employer, worse than that. And then you have small employers and then patients that are paying in high deductible health plans that are stuck paying the full list price of that product because they're not getting the benefits of those big discounts to the degree that others are. So the drug maker might be knocking on your office doors saying, hey, our prices are much lower than what you might perceive them to be, and that they're correct when they say that. Not to absolve them of any fault for our drug pricing dysfunction by any stretch, but understand they're looking at it, they're saying, look, we only got $50 for this drug. You know, why isn't the patient, why isn't the employer getting that price? It's because of the convoluted nature of our system where money can just flow in ways through broken plumbing systems. And so we did an analysis for small employers. We looked at their total aggregate spending on brand name drugs in the year 2018. They allowed us to aggregate the data for the purposes of public education. This group of small employers paid $110 million on brand name drugs in 2018. On that spend, we identified only $5 million in rebates that those small self-insured employers got. Thanks to the availability of public data, we could see that the best commercial plans were getting the equivalent of $30 million on those same drugs. So what happened? Those plan sponsors were not given the benefit of those discounts to the degree that larger employers and federal government purchasers were. This is again taking advantage of a lack of sophistication or a lack of leverage of our smallest payers, our mom and pop businesses who are paying for employee benefits, but are not given the full benefits of the concessions that drug makers are getting.
Mr. Chacha, I'm going to interrupt real quickly. I'm going to ask, I know you've got a lot more slides. We have one more presenter, and we have very limited time. So if you might want to pick out from the slides that are coming up, real quick highlights, because we want to give Mr. Barton an opportunity to talk about his slides as well.
Absolutely. Very, very much apologize for the overrun. What I would just say at a very broad level, whether it's traditional spread pricing where PBMs are paying low, billing high, pocketing the difference, forcing patients to get expensive brand name medications when generics exist, or overpaying for prescription drugs that are predominantly dispensed to the pharmacies they own, there are many different ways that a PBM can engage in what we'll call lowercase spread pricing, which is whether it's upstream or downstream, the ability for them to be a price setter and a price taker is totally inappropriate and works against the interests of the plan sponsor. In yesterday's hearing, I caught a minute of it where your Kentucky Employee Health Plan talked about how CVS Caremark was doing a reasonable job and Aon was coming to do a market check. Recognize that Aon receives big compensation from large PBMs like CVS Caremark in exchange for referrals as well. So that even the brokers and consultants who are operating in this space are not always going to be your best friend. Your job as lawmakers, as accountability experts on behalf of taxpayers, is to ensure that the incentives are properly aligned and that ultimately you're getting the best bang for your buck. Unconflicted PBMs, insurance companies, et cetera, and unconflicted benefits consultants, making sure that you get that rather than having the ramifications of the bad side of conflicts is ultimately what's going to reduce your overexposure to inflated drug costs. And with that, thank you very much.
Thank you very much. I appreciate that, Mr. Barton. If you'd like to go ahead and present your information.
Yes, absolutely. Complex stuff, huh?
Very.
Let me get my slides.
It can get
pulled
very
up
weedy
here
very
really
quick, obviously.
Fast. Oh. Let me do share screen. Oh. There, and then let me do present. There we go. Okay, well, I'll try to be as brief as possible here, but I think that maybe this will kind of bring some light to some of the examples that have been brought up today, by my fellow panelists. So kind of what I've been advised to do today is basically present to you as if you are the employer and bring real life examples kind of that we see here in the state of Kentucky on some analysis and some of the gamesmanship that's played within the traditional PBM space. So quickly, kind of where IMSONRx started. We are a PBM that is actually headquartered here in the state of Kentucky. Basically, there's a coalition of PBGH, 40 jumbo employers that represent 21 million Americans, and they have $350 billion in healthcare spending every year. This is a coalition, a nonprofit coalition of jumbo employers that are out to fix healthcare. They've been around for about 30 years. And within the last 5 to 6 years, they've really been focused on pharmacy spend. The reason being that's the highest rising cost in healthcare, as many of you may know. And kind of how we came to be was this group continued to try to find new ways, new strategies, and implementing new solutions to reduce their pharmacy spend. And they ultimately realized that they were continuing to be unsuccessful, mostly because they had the blockade of the traditional PBM in their way. And so they decided to bring a market-driven solution to the market, and that's who IMSONRx is. One more thing is that we are a public benefit corporation. So, a lot of times we say ultimately the traditional PBMs, they're for-profit companies, right? And ultimately they're just doing their job, and they're doing a really good job of their job. They're doing fantastic, right? Their job is to continue to make more and more money for their shareholders, and they're doing so every year, and they're going to find new and innovative ways to continue to do so, unless policy or a market-driven solution is brought to the market. So we set out when we were creating the foundation of IMSONRx, we did not want to become part of that same trend. So we designated ourselves as a public benefit corporation. Therefore, that allowed us to not only prioritize our shareholders, but also to prioritize our clients and our members. So again, as I stated, we are a PBM that is headquartered here in Kentucky. I'm a local Kentuckian myself. I went to the University of Kentucky Pharmacy School. And so we're going to do a little bit of a case study here on the KEHP Kentucky Employee Health Plan. So currently, KEHP is, as Anthony stated, with CVS Caremark as their PBM. KEHP is one of the largest employers of Kentucky families, so they represent about 300,000 members that are on the KEHP plan. So as kind of has been stated, Caremark is requiring members of the KEHP plan to fill prescriptions through mail order and through specialty that have to go through CVS. So those prescriptions have to be filled through those pharmacies, and therefore those prescriptions that could be filled within the state are actually being forced out of the state. So that's both revenue and jobs going out of the state. Also, historically, PBMs say, we're the biggest, right? We're the biggest, we're the best. You're a big employer group. We can use our size and your size to give you the best prices on medications. However, we know that that's different, and I'm going to show you some examples here. So here's example number one. This is KEHP's for 2021, their top 20 drug of their top 25. Millions and millions of dollars spent on this medication. This is a medication that can be acquired for cents a pill. So this first capsule that you'll see here, this is for a 90-day supply, the top number there. That's for your standard discount card. Anybody with no insurance could go out to online, a GoodRx single care website and find this price for a medication at a pharmacy. So this is a pharmacy that's willing to give this medication at a 90-day supply for $6.91. If you were to do that same search through CVS, you could find that medication for $107.48. So CVS has a little more power to kind of, they're not going to take the lowest price, and some of the independents are more willing to cut their margins. And then finally, the Caremark pricing here. So that is what members would be responsible for, that is what the employer would be responsible for someone that is contracted with CVS Caremark. So basically, KEHP, they are paying $290.74 per fill per 90-day supply for that medication.
Can I interrupt? I want to make sure everybody understands what we're talking about here. So you're saying that if you were just had a prescription from a random doctor and had a discount card, that any of us could go outside of our insurance plan and get this for $691 for a 90-day plan. But if we do it through, but if we do it through our insurance, we're being charged $290.74.
The employer is being charged $290.74 per fill.
Yeah, I think everybody needs to make sure that everybody here is aware of that's what the employee health plan for our state that provides a lot of this for our teachers, for every employee you can imagine within KEHP. That's how much more money is being spent for one prescription. Multiply that by how many people are being prescribed this medication out there. That's the kind of abuse that we're seeing. Thank you. Please continue. Sorry to interrupt.
And that's a market standard, right? That's not a KEHP thing. That's market standard. That's what CVS Caremark does. And the other thing to point out here is this is an ACA mandated drug. So patients are paying nothing. They don't care, right? They don't care how much it's costing the employer. So. And here's another example. So this one is a specialty medication. It is required to go through CVS specialty. So, and that's just why we call this out here. So CVS, this drug cannot go anywhere else for a member that's on Caremark for KEHP. And you can see, again, this is a 46 times difference of what you can get for a discount card versus what the employer is paying today. And this is just a 30-day supply. A couple other things I want to call out here. So these are some trend lines for KEHP over the last several years. As you can see, the generic percent of scripts is going down. As Anthony talked about earlier, and I believe my fellow colleagues here also talked about, a lot of times this is because formularies are designed to drive patients to branded drugs. Even though there might be a therapeutic, cheaper alternative out there on the market, they are designing their formulary to drive patients to these higher cost drugs and requiring them to get those drugs. And what that does is it allows the PBM to collect part of that rebate and make money. So, they'll often say it's lowest net cost and they'll tell, the employer, look how great it is, we're getting you all this rebate. But ultimately, there's a generic out there on the market that is much cheaper and in the long run would save much more money for the employer. And I can roll through this slide, but basically what we're trying to get across here, APW discounts. So in a PBM contract, so year over year, APW discounts should be getting better. And as you can see, that's just not the case. So when CVS put out a bid for the KEHP business, they would have gotten a bid and there would have been a guarantee that the AWP discounts are getting better year over year. And as you can see, that's not what's being reported here. Just a quick definition of rebate, very simple, and we put this in quotations for a reason, which I'll show you on the next slide. Rebate is a discount on the medication drug manufacturer gives a PBM in agreeing to cover their drug or product. So this is an actual, these are some data points actually pulled out of a true RFP for an employer. So what it's showing here is these are all the different revenue streams or savings opportunities that pharma is given to the PBM, right? So all of these are different ways for the PBM to contract savings from pharma that we think should be passed on to the employer. Unfortunately, what's really only happening is the PBM will say we're passing on 100% rebates to the employer, but really what they're only passing on is the true definition of rebates, right? So there's all these other fees that are savings from pharma that is truly part of the rebate, but they're just not calling it out like that in the contract. And so it's part of that opaqueness and that black box. We understand that there's a lot of work that goes into contracting with pharma, and that's why we actually exclude the administrative fee for that work. But we believe all of these other fees and things where savings should be getting passed on to the client, that should be happening, and it's just not. So again, the current experience for KHP, yearly spending of $557 million on pharmaceuticals. About $300 million of that is going to specialty and mail order pharmacies, which are out of the state through CVS. Those are CVS mandated prescriptions being filled. And so basically CVS is adding jobs and revenue out of our state, right? So this is an opportunity for KHP. We believe that we can bring significant savings, especially through passing on all of these rebates and all of these savings that truly come from pharma. Also bringing some of that specialty fills and those 90-day prescription fills back into our state through the Kentucky Hospital Association. That'll help us bring new jobs back into the state and new revenue back into the state. And then lastly, just more closer personalized care for state employees. And this is just my few closing statements here. As I stated earlier, most PBMs are for-profit companies, and they're just doing their job, making as much money as they can for their shareholders. We believe that they'll continue to find new ways until either policy makes the change or there's a market-driven solution that's going to make a change. 100% rebates are bad. Again, going back to that slide, there are many, many other savings coming from pharma. It's not just the one that's defined as rebates, and that should be getting passed on to the client. CVS Caremark is negatively impacted. Just think about how, if CVS Caremark is doing these types of things to KHP, what are they doing to smaller employees throughout the state? And then lastly, we are a public benefit corporation and focused on doing good for the Commonwealth.
Thank you all, gentlemen, very much. It's a lot of information, obviously, and it's complicated. We just had a presentation from KHP yesterday in state and local government, who said that they have an incredibly transparent contract, and clearly I don't know how much that they're aware of that this is going on within their own. And if the commissioner is watching, I asked yesterday for her to watch and tune in. You can see the opportunity I think that we have for savings, really for healthcare for all the state employees who are part of that plan as well. We do have a couple of questions. The first one is from Representative Bentley.
Thank you, Mr. Chairman. My question goes to Dr. Barton. Most PBMs belong to PCMA, right?
That is correct, sir.
Are you a member of PCMA?
We are not. Ironically, we actually tried to be accepted into PCMA, and mostly because there's so much legislation state to state that's currently happening, and they keep up with the regulations and help pass on some of that knowledge. So that's really what we were leaning on PCMA for, to try to get. However, when we applied, we were denied because they didn't believe in necessarily our mission and some of the things we were trying to do in this space. So we were denied admission into PCMA.
So you're telling me because you're transparent, they wouldn't elect you in the association?
Part of that, yes.
Thank you. We went to the same college.
Thank you. Senator Carroll.
Thank you, Mr. Chairman. And gentlemen, thank you for the presentation. I think we are all sufficiently irate at this point. Help me understand with the discount cards, where does that fall within that chain? Are those prices an indication of what the fair market value would be if the PBMs played fairly? Or where do they fall?
Yeah, I mean, I think a lot of it has to do with the PBM is deciding what it pays its own pharmacy, right? So, and that's part of the trouble with this is, we'll never own our own pharmacy. I think Capital RX probably has the same position. We think that's where a lot of the trouble is when they're deciding what they pay themselves. The other concerning point is that high price that you see there that they're paying, for KEHP example, that's probably not the price, even though they're probably charging the employer that price for independent fills. That's not the price they're paying those independent pharmacies. They're getting much less, and that's where that spread pricing happens.
I guess I'm still not clear. So the discount card, like with GoodRx,
Yeah.
are they a pharmacy within themselves, and do they fall within that chain?
Yep.
Explain to me what they are and how they can do what they do to get prices so cheap.
Yeah, and again, it's a little complicated, but I think I can break it down. The discount card is quietly behind the scenes, basically leveraging existing PBM network deals. They have a sort of an array of them that they triage the claims to for the lowest available price. While the perception in the industry right now is that drives a lower cost for the patient, In reality, it still has a tremendous amount of margin built into it. Okay, and that's because behind the scenes, behind every good RX, behind every discount card, is an array of PBMs leveraging spread pricing arrangements and extracting margin, sometimes $6 to $11 per claim. So when you get the right infrastructure in place with pricing, ours is NADAC based, I mentioned that earlier, we end up beating good RX about 85 to 90% of the time.
Thank you, Mr. Chairman.
Thank you. Representative Margin.
Thank you so much. This is fascinating. I'm over here. I have a question on, so the if you have the RX card, it's $6. The real expensive one was like $1,100 for a year, then they're charging KEHP $1,100, right? So how much are they paying the drug company for the medicine that they're charging $1,100 for? And how much are they paying the pharmacy if you don't go to their Caremark pharmacy? How much are they making out of that money? So how much is the PBM putting in their pocket? Do you understand that question?
Yeah, so I mean, it really comes down to how much is the pharmacy purchasing it from the wholesaler for, and it's going to be lower than all of those prices, right? They're going to be getting it the best price. And then in that example, that was Caremark paying CVS, which Caremark owns, right? So they're paying themselves, so they're collecting all of that. We don't know what they paid for the drug, but it's going to be cents. It's going to be very, very minimal. It's going to be a small amount.
Shoot, they're making a lot of money.
Yeah.
Thank you very much. Any other questions from members of the committee? I know that's a lot of information. Go ahead, please, Representative Fleming.
Thank you, Mr. Chairman. Sort of a naive question. Why are some prescriptions more profitable than the others?
So if I could, I'd love to step in on this one. So in our research, if I was to walk you behind a pharmacy counter, I would be able to show you how pharmacy experiences economically. And this is ballpark here, right? But take me at my years of experience here. About half of the prescriptions that a pharmacy dispenses are going to be done at a loss, meaning that they're not covering their overhead costs, and in many instances, they're not even covering the cost of the medication itself. Then you have about 40% of claims that are paid what I would just loosely categorize as a break-even proposition for the pharmacy, meaning that they've covered the cost of the drug and they're making enough margin to cover their overhead costs. So let's just say a ballpark of like $5 to $15 in profit. It usually, on average, costs a pharmacy anywhere from $10 to $11 per prescription to break even if they're making profit on that. But then there's that leftover sliver, that 10%, where pharmacies are wildly overpaid for medicines. While pharmacies need around $10 to break even, we see instances where pharmacies can make hundreds, if not thousands of dollars on a single claims transaction. So a good example would be like a generic Gleevec, which is a popular, leukemia medication, generic Tecfidera, which is a multiple sclerosis medication. They're expensive medications that are traditionally told, or through benefits design, the PBM says, you have to get that medication at the pharmacy we own, the specialty pharmacy we own. But they can't force everybody. There are some plan sponsors that will say, look, we want open access. There are some plan sponsors that will incentivize a patient to get their medicines at the PBM-owned pharmacy. But the key here is that some pharmacies will benefit from how PBMs can wildly overprice a medication. What our research typically shows is that when pharmacies make a lot of money on specific drugs, those are drugs that are traditionally disproportionately being dispensed at pharmacies owned by the PBM. So they're willing to overpay when they know that money will flow down to their subsidiary affiliates, right? So I'm willing to overpay for the generic Gleevec because I know that the PBM, will downstream fill 80% of those claims or 70% of those claims. So sometimes pharmacies can make a lot of money, but recognize usually when that happens, it's a direct relation to the conflict of interest that the PBM has when they're paying its own company.
Boy, that's a nice clear picture for me. I appreciate your explanation.
Thank you. I have one question I think that probably on a lot of people's minds, because we hear a lot about it in the national discourse, and there's been even some federal discussion about policies about repurchasing drugs from other countries because they're cheaper. And we have, I went to an employer this morning in my community for a tour of their employer, and we talked about this, how this guy winds up going to another country to purchase his medications because it's so much cheaper than what he can get it for at our pharmacies here in our state and in our country. Could you all perhaps talk about that? Why is it the case that we have certain medications that are pennies on the dollar compared to what Americans pay and what we would pay here in Kentucky versus what other countries do?
So I do a lot of international pricing research myself. So there are, just like within different benefits designs, you will find some medications cheaper under some plans versus others. You'll find some medications cheaper at some pharmacies versus others. The same thing is true with international pricing. In many instances, we will find that brand products will be cheaper in many of the international comparators from a U.S. perspective. But then we also typically see that generics are more expensive internationally. One of the trade-offs is that a lot of those international countries will do one of two things. One is they are engaging in price control. So, to the degree with which those have aversion to too much government input into pricing, well, recognize that many of those countries are engaging in just straight up price controls. They're setting the prices for everybody. What that also means is that can hinder access to medications in those countries. So we'll either see delays where drug manufacturers will delay launching a product in a particular country, or they just won't even have it altogether. In order to engage in price controls, those international countries are doing a lot of what PBMs sometimes do, which is say, look, we're not going to cover this medication at all unless you give us a big discount. The country is making a unilateral decision, and what that ends up doing is it divorces choice out of the matter. In the United States, we'll have this unique pricing dysfunction, right, where the prices are way overinflated. At the end of the day, we still have our choice into availability, and that choice is not available in a lot of the countries that engage in those price controls.
Anything else you gentlemen would like to add onto that? Or I'm just always curious because we hear that discussion as an option all the time, and I've always thought a lot of it had to do with R&D, that a lot of that's done in our country, and other countries wind up benefiting from the research and development that we do in our country and often get them at a cheaper price.
Yeah, I have very little to add to that besides the fact that it really does depend on the comfortability of the plan sponsor as well, right? These products are not necessarily covered by the FDA. Right, they're running through a different regulatory body, so there are rules that actually state legislatures dictate when a plan sponsor within that same state's jurisdiction decides to cover those out-of-state drugs. I think a few examples that come to mind are Vermont and Utah that have at least dove into the world of international drug pricing and brought them into the state in one aspect or another. So it's a pseudo-regulatory function, but there is obviously a risk when it's not necessarily the United States controlling that drug supply.
Yeah. I mean, we've seen some clients attempt to pursue this as a sort of an interim solution, right? One other thing that's important to note on this is that it relies on a smooth international logistics system to get drugs flowing on time. I mean, these are patients that rely on drugs month to month, day to day. What we saw during the pandemic was a big drop in interest in this. Frankly, the international logistics just wasn't able to keep up with a steady supply chain. So, that's another consideration, especially when we're talking about life-saving medications.
Well, thank you, gentlemen, very much. Like I said, it's a lot of information. I know there's a couple other handouts that we've got. I would encourage members to take a look at this pipeline to profits, which kind of shows you a little bit of a cash flow. Those kind of graphics always help me to get an understanding of where dollars flow. Like I said, it's a very complicated process, but I think it's helpful. And also a pharmacy benefits report for 21 and 20. You can kind of take a look at a lot of the numbers of how much we're talking about in terms of dollars there. Gentlemen, thank you all so much for making the trip today and coming in. And I appreciate we've got, again, I always talk about having good partners in healthcare. And I feel like sometimes we've made contracts with partners that aren't transparent, aren't fair. I appreciate that we have people out there trying to do the right thing. And that's just really important for us going forward. Hopefully that'll catch on and we'll see more companies like your own do very well, not only in our state, but across the country. All right, we're almost at the 2-hour mark. I know we had two more presenters that I'm going to ask I've already texted them and asked them to please, we're going to probably defer your testimony for a future meeting. So please keep a lot of that. And I appreciate y'all coming and being willing to testify today, but we've kind of run out of time. And you can see we needed to devote one entire meeting towards having this discussion because it is very complicated. And I'm hopeful to see, even though Representative Sheldon, you're not going to be with us in the next session, hopefully this bill is going to come back so that your work is not in vain. And it sounds like we have partners out there who are in this space who would support it. So I'm very hopeful that we'll see efforts, and I would encourage members to take a look at that. If you have any discussions, again, Representative Sheldon is the expert in this, to bring your concerns to him. Our next Interim Joint Committee on Health and Welfare meeting is going to be on Wednesday, October the 26th at 11 a.m. Other than that, unless we have any other issues, we're going to stand adjourned. Thank you.